You finish chemotherapy, the cancer is gone, but your hands and feet still tingle and burn, and they go numb. Your oncologist told you it should improve with time. For some patients, it does. For a significant number, it doesn't. And the reason has nothing to do with how your chemo went. It has to do with what chemo actually does to nerve cells and why that damage doesn't always reverse on its own. Chemo neuropathy is not just a side effect. For 1 in 3 patients, it's a lasting condition. That's why we're here. Here's why, and what can actually be done about that. I'm Dr. Bruce Stevens. I specialize in neuropathy, including patients whose nerve damage came from chemotherapy, one of the most underserved populations in the country. I want to explain why chemo neuropathy persists in some patients, what the evidence actually says helps, and why the wait-and-see approach has a time limit. We'll cover the mechanism, in other words, the gap in standard oncology follow-up, what treatment options have, and which ones has real data, and what to ask if you're still dealing with this a year or two away from your chemotherapy. Let's get into it. Why chemo neuropathy doesn't just go away. I want to start here because I think it's where most patients need to begin, with validation. That tingling that never went away after chemo, the numbness in the feet, the burning hands, that's one of the most underreported and undertreated consequences of cancer treatment. It has a name, chemotherapy-induced peripheral neuropathy, CIPN. And before we talk about why it lingers, I want to just have you hear this. 30 to 40% of patients who develop CIPN during chemotherapy face long-term nerve damage, not a temporary side effect that fades in a few weeks. For patients treated with oxaliplatin, specifically a platinum-based drug used in colorectal cancer, the numbers are striking. 58% had measurable CIPN at 6 months post-treatment, 45% at 12 months, and 24%, roughly 1 in 4, still had significant symptoms at 3 years after the chemo ended. Now, I want to be clear, some CIPN does resolve. If you're in that 6 months after treatment, your body is still clearing the drug and beginning its natural repair process. Waiting and monitoring does make sense during that window. But at 6 to 12 months with no meaningful improvement, wait and see stops being a treatment strategy. It becomes a gap in care. The question is, why do some patients recover during that window and others don't? And the answer comes down to what the chemotherapy actually did inside the nerve cell, which is what I want to talk you through next. So what chemo does to nerve cells? This is the part most patients have never been told. Not because it's being withheld, but because oncology and neurology are two different specialties. Oncologists specialize in cancer. The biology of what happens inside the nerve after treatment is a different lane. So let me walk you through it. These are two primary mechanisms that explain why chemoneuropathy can persist long after the drug is cleared from your body. The first applies to taxane drugs, paclitaxel, docetaxel, used in breast, ovarian, and lung cancer. These drugs interfere with microtubule function inside the nerve cell. Here's what that actually means in plain terms. Inside every nerve fiber, there's an internal transport system like microscopic supply chains running from the cell body all the way down the axon to the nerve endings in your hands and feet. That supply chain depends on structures called microtubules. They're like the rails that the freight car runs on. Taxanes lock those rails. When microtubule function is disrupted, the nerve ending gets cut off from the proteins and nutrients needed to survive and actually function. The second mechanism applies to platinum drugs, oxaliplatin and cisplatin, used in colorectal, ovarian, and testicular cancers. These drugs directly damage the mitochondria. Mitochondria are the energy generators inside the cell. A nerve cell they're among the most demanding in terms of energy. Cells in the human body, they need a constant supply of energy to maintain the nerve signal, to repair and regenerate. When mitochondria are damaged by platinum chemotherapy, the nerve loses its energy and just begins to shut down, as it needs many of those things. Now, here's why this matters for persistence. The chemotherapy drug itself may clear your system within days or weeks, but the damaged mitochondria and the disrupted axonal transport system actually remain. The drug is gone, but the damage is still there. And peripheral nerves are slow healers. They regenerate at approximately 1 to 2 millimeters per day. In a damaged environment without enough energy to drive the repair, the window for meaningful recovery gets narrower and narrower as long as it goes unaddressed. I'll mention more on this later because actually here I want to discuss, I think it's worth knowing that where science is heading. Researchers have recently identified a specific molecular pathway called the IRE1 alpha XBP1 pathway that activates in patients who develop severe CIPN. What's remarkable about this is findings in this pathway appear to activate before significant nerve damage develops. Scientists believe this may actually and eventually enable a blood test to predict which patients are highest at risk for symptoms before they even appear. We're not there yet, but it tells you the science of CIPN is advancing. Before we get into the treatment evidence, if this is giving you a clear picture of what you're actually dealing with, hit subscribe. I put out this kind of clinical detail specifically because chemo neuropathy patients are among really the most underserved in neuropathy. And this channel is built for you. The oncology gap. I want to be careful on how this is framed because what I'm about to tell you, it doesn't describe, it's not criticism, it's a structural reality of how specialty medicine works. Oncologists specialize in cancer. They are focused on remission, on monitoring for recurrence, and long-term cancer surveillance. And that's exactly what they should be doing. They're exceptional at what they do. But neuropathy is a separate specialty. The treatment frameworks are different. The follow-up protocols are different. And oncology practices do not have the bandwidth, the training, or the infrastructure to run a parallel neuropathy management program alongside cancer care. It's a lot to deal with. That's not a criticism of oncology. It's simply the nature of specialty medicine. They need to stay focused. What this means for patients is predictable CIPN symptoms are often recorded and monitored during treatment, but once you move post-treatment, the follow-up in neuropathy frequently gets managed as a side effect to watch rather than really conditioned to treat the mechanism at the level. Referrals to neuropathy specialists for CIPN are less common than they should be. Many patients receive gabapentin, which addresses pain symptoms, and are told to follow up with primary care. Primary care, without neuropathy-specific training, often defaults back to the same approach. A lot of roads lead back to gabapentin. The result is that many cancer survivors who've beaten the disease are left managing a chronic neuropathy without anybody actively looking at the root cause or where it's headed. The question I want you to leave with in this section is, has my neuropathy had a dedicated evaluation separate from my cancer monitoring with someone who specializes in neuropathy or neuropathy care? If the answer is no, that's the gap that this video is designed to help you identify. What actually has evidence? Let's talk about that. We'll start here. Most CIPN patients are given what the evidence actually says about those options: gabapentin and pregabalin. These are two of the most commonly prescribed medications for neuropathic pain, and they have reasonable evidence in certain neuropathy, diabetic neuropathy, and post-herpetic neuralgia in particular. But CIPN-specific evidence-based is much, much thinner. These drugs weren't studied primarily in CIPN populations. That doesn't mean they can't help some patients manage the symptoms. It means the evidence is weaker than many patients are actually led to believe. Duloxetine, this is where the best CIPN evidence lives. Duloxetine is an antidepressant that also has analgesic properties. That has the strongest evidence for reducing CIPN pain specifically. ASCO guidelines acknowledge it as the most evidence-supported pharmacologic option that we currently have for CIPN-related pain. Two important caveats, though. It is not FDA approved specifically for CIPN, and it addresses pain. It does not repair nerve damage or address the underlying mechanism. As of 2025, no FDA-approved pharmacological treatment exists specifically for CIPN. That's not a statement about hopelessness. It's a statement about where the research frontier currently is and why the evaluation framework really matters to you. Now, let me talk to you about a few categories that address nerve recovery and the environment needed rather than just the symptom. B12 and nutritional support. Many patients who've been through chemotherapy have nutritional depletion that compounds nerve damage. B12 deficiency is particularly one well documented. It's a cause of peripheral neuropathy in its own right. If a B12 deficiency is present alongside CIPN, repletion removes a barrier to nerve repair that doesn't need to be there. Antioxidant support targeting oxidative stress. There is emerging evidence that targeted antioxidant approaches can support mitochondrial function in nerve cells, which is directly consistent with the mitochondrial damage mechanism I described in Section 2. Neuromodulation. There are emerging non-pharmaceutical approaches that work at the level of the nerve environment without adding medication as a burden that patients are already often carrying a lot of after cancer treatment. This is worth discussing in a specialist evaluation. What a proper CIPN evaluation includes and what standard oncology follow-up doesn't have time for. Here's what it is. Quantitative sensory testing. This gives us objective data on small and large fiber function that a symptom questionnaire can't really capture. A nutritional panel, B12, vitamin D, full metabolic profile. Removing nutritional barriers to nerve repair is the first step, then shouldn't really be skipped. Neuropathy-specific clinical scoring separate from oncology side symptom reporting, and ideally a specialist evaluation before the 12-month mark. The window for nerve recovery narrows over time. The earlier it's detected and evaluation happens, the better conditions for meaningful improvement exist. If you're a cancer survivor and still dealing with nerve damage after chemo, you're not imagining it, you're not being dramatic, and it should improve with time has a time limit. The mechanism that drives CIPN in patients who don't recover is real biology. Mitochondrial damage, disrupted axonal support. A nerve repair process can't run efficiently without the right conditions and the right evaluation. They can be addressed, but only if someone is actively looking at the neuropathy. Not as a chemo side effect, you just wait out, but as a condition in its own right. Here's what I want you to take from this. 1 in 3 patients who develop CIPN face lasting nerve damage. This is not a temporary side effect for everyone. The mechanism, mitochondrial damage, and axonal transport disruption explains why some cases persist regardless of how well the cancer was treated. The oncology gap is structural. Cancer specialists manage cancer. Neuropathy specialists manage neuropathy. They are often not the same provider. Duloxetine has the most evidence for CIPN pain. No drug is FDA approved specifically for CIPN nerve repair. Root cause evaluation and support have emerging evidence and should be a part of any serious CIPN workup. The window for nerve recovery narrows over time. An evaluation by a neuropathy specialist, ideally before the 12-month mark, gives the best chance of meaningful improvement. You beat cancer. You deserve someone who's actively managing what came after it. If you want to understand whether your neuropathy, CIPN or otherwise, is progressing or holding steady, I did a video on the 7 clinical warning signs I look for in my clinic. That's worth watching if you want to track where things stand. If you've been told there's nothing more that can be done, the Why Most Treatments Fail video makes a case for why that answer usually means the wrong framework was applied, not that nothing can actually help. If you're a cancer survivor and this gave you something you didn't have before, drop a comment. Tell me how long you've been dealing with chemo neuropathy. Drop the number of years below. I read them, I respond to them, and subscribe if you want more of this. I put out clinical content just like this every month because this community deserves more.